But the book, some of this is in chapter 35, and also a lot of them do the review for the final as well, and they post it.
Oh, yeah.
So I mean, I know at least Jamie always did, so that helps too. But I thought the book had some interesting. It has a lot more that they're developing now than ever. These are still going to be your two hallmarks. So we need to compare and contrast these as your most common ones you're going to be exposed to in your normal lab. Maybe if you're a nurse in the intensive care, you're going to get more detailed information on using other types of coagulation inhibitors, like your streptokinase, staphylokinase, urokinase, TPA, maybe an ER, because then who are they working directly with? The pharmacy. So that doesn't really necessarily go through the lab that we're going to know about it, other than when they used to order thrombin times more commonly, and if it was a patient in intensive care, you almost knew it was going to be abnormal because they might be on something besides Coumadin and heparin because it wasn't working, whatever they were trying to prevent clotting. So an intensive care nurse probably and an ER nurse might have more direct connection to some of these newer direct inhibitors. There's some that directly act on 10, some directly act on factor 2, and if they can have it act directly on the thrombin clot, like plasmin can be dangerous. If it goes crazy like in DIC, it's affecting your ability to clot. Was if you can give the patient something that goes straight to where the blood clot is, but you have to monitor them so you don't put them in a bleeding state. You might have help their therapy, help their stay be less. So it's kind of exciting what's starting to come about now besides heparin and Coumadin. So the big thing you're going to have to be aware of, what happens, Coumadin, if you compare them, you should be able to tell me some the key differences. And this is, when I talk about heparin, they call it, when it's full heparin, unfractionated, or whole. When we get into heparin, there's also low molecular weight. But when I'm comparing them, we're doing whole heparin, unfractionated. We're not talking about low molecular weight, which is part of truly the whole molecule of heparin. This one is very slow. The book says more 4 to 5 days it does its effect, but 3 to 5 is fine because some people it's going to make its effect faster, especially if they watch their diet and eliminate all the foods that can have vitamin K in it. But this is slower. Many times in 1 hour, the book says 1 to 2 hours, it can act. So it is very hard to monitor heparin as an outpatient. So normally if someone comes in with some kind of blood clotting, they're going to put them on both, because if you only put them on Coumadin, you might already die of a heart attack or a stroke or a DVT because it doesn't get to the right proper INR for 4 to 5 days, 3 to 5 days. So most cases, pay attention when you're working in coag, especially if you know it's a new patient. You'll start noticing the pro time takes its time to rise to 2 to 3. But that heparin level, most labs go by a 60 to 80 second PTT that they know the heparin level's good. They're getting to this anti-10A assay, which is a better monitoring test. But if you have a clot right now, you put that person on Coumadin and you're probably going to have potential problems, because you got to have an effect right away. That's where in the hospital setting, most of the time, at least for the first 5 days, they'll be on both. Then as the INR gets between 2 and 3, they can remove the heparin. Do you remember what also I said in regard to antithrombin 3? They're cofactors, so what's going to be the issue with the longer you're on heparin? What happens to that antithrombin 3 level? Decreases, so that heparin's not going to be as good. So you might have patient A in bed 1 starts out at, let's say, 5,000 units of heparin, either intramuscular or IV, and then patient B a week later starts out at 5,000, and when patient B is on day 2 and patient A is on day 7, they both have the same PTT. And you're saying, how can that be? Patient A has been on it. How is it not higher? It's been on it longer, more time to take its effect. The antithrombin 3 levels drop, that PTT drops because it can't do its job. That's another reason you got to be on another anticoagulant. Because Coumadin, once you get to your good INR, it's good. It's not going to drop off because of something decreasing, like heparin drops off when antithrombin 3 levels decrease. So heparin is not your foolproof anticoagulant. So it's great that they're coming up with some other ideas. It was developed as rat poison in 1948, and that's how, basically what rat poison is. It'll make them bleed to death. And it affects vitamin K dependent factors, the 2, 7, 9, and 10, but it's monitored primarily with the ProTime because the 7 needs to be made more quickly. It has a quick turnaround time. Now, you're going to see it basically with any kind of blood clot, whether it's venous or arterial and maybe a main artery in the heart. In most cases, they're going to have them on both, if not add more to that protocol. But anybody with any kind of blood clotting, that's going to be their standard protocol. Get them on Coumadin, get them on heparin. If that doesn't work, then you're going to look at these other types of anticoagulants that are coming out. One of them, like Plavix, affects platelets. And I thought it was an interesting thing here with the platelets. They are commonly associated with arterial. Their arterial thrombosis is often caused by interaction of platelet and vessel wall with the atherosclerosis, how it forms plaques on your vessel, is commonly platelet. Venous thrombosis is often associated with abnormalities in your clotting factor systems. So it's interesting which one's more associated. So if they're worried about you more having arterial thrombosis, they're probably going to do aspirin, Plavix. If you might have a deep vein or venous thrombosis or something they know is in the vein, they're probably going to look at long-term Coumadin. So yeah, I thought that was even interesting in your chapter. So chapter 35 has it, but commonly, you're going to see Coumadin and heparin is going to be your big keys to. And we already know the INR for normal people that have not had reoccurring blood clots, the normal people are going to need to be an INR between 2 and 3. If you have someone this is their 4th heart attack, no, you're going to need an INR probably between 4 and 5 or 3 and 4 or something. But your normal patient, typically, you get them between 2 and 3, and it's good. And the first thing, if they're not getting into the proper 2 to 3 quick enough, you're going to start looking at their diet first. What are you eating that could be inhibiting the Coumadin? So there should be a dietitian or some diet that they can give a person who's on Coumadin to let them know what to avoid. For instance, foods high in vitamin K, like green tea, salad, green vegetables, soybeans, avocados, ice cream, they can decrease the effect. Cranberry juice, we all know alcohol, like the girl I told you that has the protein C deficiency. She just had a baby. My daughter just had a baby 5 months ago. And this is the first time when you're breastfeeding, you're not going to be drinking. And so they were both excited. Katie's not, once she got her blood clot in the lung, stopped breastfeeding and everything. But she had to worry. I mean, Nicole dumped and pumped. I was the designated driver, took them, picked them up, because they don't ever have any family to have any fun. But Katie couldn't. She's on Coumadin now because of that PE. And before, when she just had the 2 DVTs, they were able to put it on just a short period of time and take her off. But now that's a big deal. I mean, you're only 32 and already you got a lifetime of worrying about blood clots. So it's a major deal when your blood inhibitors of clotting that we've discussed don't work. So you know they have to give them a diet, anybody who's starting Coumadin, or it's against the physician not to let them be aware of what might have vitamin K in it. And when you go, and your ProTime and PTT is your common test that are going to be abnormal, 90% of your abnormal ProTimes and PTTs in your routine labs are going to be because they're on heparin or Coumadin. Rarely are you going to get to see true deficiencies in your career working in the normal coag lab. Unless you get to work in the special coag lab, you're not going to see many true deficiencies. Maybe if you do bypass surgeries a lot, you're going to see fibrinogen bottom out where they have to give them FFP. They have a new emergency there. Eric was telling me he was in blood bank, and Teresa was in blood bank. He had just gotten out and he was working as a lab assistant, and they have a new protocol. If someone bottoms out and is bleeding profusely, they have to give them packed red cells. I think he said for every unit of packed red cells, which is just red cells without all the plasma with it, then they have to give them a bag of FFP, and then once they get to, I think, 5 units and FFP given, they got to give them a thing of platelets. You have one person working in blood bank, and you have one patient like that. She was having to do so many blood products between packed red cells, FFP, then platelets, that it was crazy. So he said blood bank is the one place they have a lot of great machinery until a patient goes bad. And then, oh my gosh, one person to try to keep up, or you have a person that has an aneurysm burst, you can't keep up with all the units of blood they go through, because that's an actual artery that bursts from a getting weakened vessel. Okay, so let me give you the treatments. So we'll pick up where we left off on Thursday.
I got one, so let's get it too. He gave me one, remember, for the test, because I had to use.
Oh, okay. That was that one? Okay, and then you can just pass one over to Tiana. Okay, and then this is the take-home test. So just bring these both back on Thursday. And then we'll finish up, and that'll be our review of this. And then we'll do the Jeopardy thing on the rest of them. You need one more. Is there any more coming? You might, here, take these, and Jen, you may pass over too. There's extra tests here. Okay, so that's what, let me go get the sophomores. That will be our goal. And anybody have their disease state? This is a folder if anybody has it. I didn't want to put them just with my papers in this folder. And portfolio, if you want the extra credit points, you got to bring it in. So if you want the extra credit, yeah, Thursday. Yeah, because then I can give it back to you that day or by, otherwise if you give it to me all on the final, I'll have too many to look through.